Our presenter this afternoon is Catherine Skefos, Master's of Science and Master of Arts.
Exactly, and she's CGC is Certified Genetic Counselor.
There we go, Certified Genetic Counselor at the Clinical Cancer Genetics Program at the University of Texas, MD Anderson Cancer Center in Houston, where she provides cancer risk assessment and counseling to patients in the endocrine center. As a genetic counselor working with both pediatric and adult patients, she helps patients and family members understand and adapt to information about genetic testing and inherited cancer risk. Prior to becoming a genetic counselor, she received a master's degree in medical anthropology from the University of South Florida, where her research focused on healthcare assessment and health disparity. Catherine has a special interest in teaching, particularly educating healthcare providers about the utility of genetic counseling and testing with the goal of improving patient access to genetic services. I give you Catherine Skefos.
So I'm going to start with giving a genetics 101, the same type of overview of genetics that I might give a patient that I'm seeing in clinic. And then we're going to go into a little bit more detail about the two conditions that we associate with hereditary medullary thyroid cancer, MEN2A and 2B. And then we'll talk a little bit more about communicating about hereditary risk with family members, since I know that that can be a really trying topic for a lot of people when they do find out about hereditary risk in their family. So first things first, what do I need to know about genetics? So we all are born with over 20,000 genes in every single cell of our body, and our genes provide the instruction manuals for how our bodies grow and develop. So of course we have genes related to our eye color and our hair color, but for our purposes, I'm more interested in those genes that are meant to protect us from developing cancer. They can do that by telling our cells when it's time for them to grow and divide, and they can do that by telling our cells when it's time to stop growing and dividing. And our bodies just have a fine balance of these different instructions to ideally prevent us from developing cancer. Our genetic information is, do I have a pointer on here?
No, it does not. I'm sorry.
Oh, okay. Our genetic information is packaged into our chromosomes, and we receive one copy of each chromosome from each parent. These chromosomes, our genetic information is packaged up, and it's divided into discrete units called genes. And these genes, you can think about like a single book in the library of our genetic information. These genes provide a specific template for creating proteins. The proteins are what end up sending those signals within our body to tell our cells when it's time to grow, stop growing, and keep them acting how they should, ideally. If a person is born with a difference in one of those genes that's meant to protect us from developing cancer, they may have an increased chance of developing certain types of cancers. There is a somewhat popular adage in the world of cancer genetics that while not all cancer is hereditary, all cancer. We're in Dr. Who's lecture before this, you have heard about all of the different genetic differences that can happen within a cancer cell or within a population of cancer cells that cause it to become cancer in the first place. When we think about medullary thyroid cancer specifically, we know that a majority of it is sporadic. It happens by chance. It's due to specific genetic alterations that happen right there within the thyroid cells that cause it to turn into medullary thyroid cancer. When we take all medullary thyroid cancers that are diagnosed, 25% of those fall into the hereditary category. And we'll talk, of course, more about that as we go. So one thing I like to talk about up front is the difference between somatic and germline testing. Because when we look at a cancer, and whenever we do genetic testing on a cancer, we expect to find genetic differences. Like I said, that's what caused that cancer to become cancer in the first place. Then the question becomes, was this person born with a mutation that increased their risk of developing this cancer in the first place? Or did they acquire that mutation over the course of their lifetime and it just happened specifically in the thyroid itself? So when genetic testing is done on tumor tissue, that's called somatic testing. But when genetic testing is done on healthy tissue, we call that germline testing. Germline testing is usually done on blood or saliva. In little kids, we can use a buccal swab or cheek swab to get some of the genetic information. And then for patients who may have something like a leukemia, where we cannot use blood or saliva as our healthy tissue, we instead would have to do a skin punch biopsy. If a mutation is found to be germline, that provides really useful information for the patient, not only about why they developed the cancer, but also about whether they may have an increased chance of developing other cancers or tumors in the future. And of course, that information is also useful when shared with family members. I want to take a moment here to talk a little bit about genetic counseling specifically. Sometimes when people have genetic testing done, it is done directly through their doctor. And sometimes they meet with a genetic counselor upfront to discuss testing. And so genetic counseling is the process of helping people understand and adapt to genetic contributions to diseases. Genetic counseling appointment, I take a thorough family and medical history to help interpret that to assess the chances of there being some sort of hereditary factor at play for why a cancer has developed. I educate folks about inheritance patterns, testing options, even the logistics of testing and things like that. And then if a patient is positive, I provide counseling to promote adaptation to that new information about themselves and their family. During the appointment, as I mentioned, I take a family history to evaluate it to determine what type of testing is indicated. Are we specifically concerned about the medullary thyroid cancer, or is there anything else in the family history that we need to be thinking about in terms of hereditary risk? Based on that information, I help a patient come to a decision of what type of testing are we going to do and walk through the informed consent process. Some things that I think about when I'm taking a family history. We know that any patient with medullary thyroid cancer meets criteria for genetic testing, and I'll talk more about that in a moment. But I am also paying attention to other cancers in the family that would not be related to medullary thyroid cancer. Things like ovarian or pancreatic cancer, early onset breast or colon cancer that might indicate some other type of hereditary risk in the family. The patient has had more than one type of cancer, if they have a strong sort of pattern of family cancers. Those are all things that I would take into account when determining the best type of testing. Certain cancers that we see in the family history, though, like lung cancer, lymphoma, bladder cancer, these tend to be less concerning from a hereditary cancer perspective, particularly if they're diagnosed at older ages, where a person might have had environmental exposures or things like that that influence their risk. So let's say that this patient where the arrow is pointing to, they've been diagnosed with medullary thyroid cancer. I'm taking their family history, and there is no family history of medullary thyroid cancer, which is reassuring. But if we see a strong family history of breast and ovarian cancer, that is something that's also very important for us to address in that appointment, because there also could be additional risks posed to them based on that family history. I also go through, of course, the informed consent process with patients to talk about things like the limitations of genetic testing, possible results that we can get back, and to address any concerns that patients might have, rightly so, about things like privacy, confidentiality, and genetic discrimination. I also like to mention here that there's a federal law called the Genetic Information Non-Discrimination Act that protects against discrimination when it comes to health insurance and employment. So health insurance companies are not allowed to use genetic information to discriminate with things like cost, coverage, premiums, that sort of thing. GINA protections do not apply to new policies taken out for things like life insurance, long-term care insurance, or disability insurance. So for some people, that is a concern, and we can talk through what those potential risks might be with relation to those types of insurance plans. As I mentioned before, saliva or blood is the typical type of sample that we use for this testing. The cost is typically covered by insurance if a patient meets criteria, which all patients with medullary thyroid cancer do meet criteria for testing. But sometimes there can still be an out-of-pocket cost due to deductible or co-insurance. in which case many labs offer some type of patient assistance program to help make testing as affordable as possible. Results of genetic testing, there are 3 different types we can get back. A negative or normal result means that there was no mutation, no genetic difference identified that would contribute to an increased risk of cancer. The result means that we did find a genetic difference. I'll talk more about what that looks like in a minute. Then there is a possibility of getting an uncertain result. This type of result happens when the lab comes across a small difference that they just haven't seen often enough to know whether or not it contributes to the risk of cancer. We're usually pretty reassuring about those uncertain results, especially when it comes to the Rett gene, because we do know a whole lot about the Rett gene in comparison to some other genes that are on these tests. So usually we're pretty reassuring about those uncertain results, but it is something that genetic testing. So what is the difference between sporadic and hereditary? These are sort of the 2 buckets that we usually thyroid cancer in when we're thinking about sort of its origin or its etiology. So we call a sporadic medullary thyroid cancer sporadic when we don't see a family history of medullary thyroid cancer. It's more common to be unilateral or unifocal, but most importantly, there's no germline Rett mutation identified. That really is the definition of sporadic. Until we've done that germline testing, we can call it apparently sporadic, which you may have read in notes from your doctors or things like that. So we can say apparently sporadic, but if we've done the germline testing and it came back normal, that's when we can officially classify something as sporadic. Hereditary, on the other hand, we may see a family history of medullary thyroid cancer, or we may not. Oftentimes we may not. A person may have a personal or family history of other neoplasms that we can see going along with hereditary MTC, like pheochromocytoma or primary hyperparathyroidism. These tumors are more likely, these cancers rather, are more likely to be multifocal or bilateral and associated with a precursor called C-cell hyperplasia. But again, this is not always the case. And by definition, these hereditary MTCs are associated with that germline Rett genetic difference. Genetic testing is recommended for all patients who are diagnosed with medullary thyroid cancer. As I mentioned before, when we think about all medullary thyroid cancers that are diagnosed, about a quarter of them fall into that category of being hereditary. But when we see a patient with apparently sporadic medullary thyroid cancer, so there's no family history that we know of, there's no other conditions that they've been diagnosed with that make us more suspicious. When I'm seeing that person in clinic for the first time, I tell them that there's about a 7% chance that they would test positive for a Rett mutation. Now, 7% and 25% sounds very different, and this can be a source of confusion for some people. But what we have to remember is that 25% that we say is hereditary, that includes all of those medullary thyroid cancers that are diagnosed in families with a known mutation in the Rett gene. So that's different from a person sitting in front of me who has no known family history, no other known manifestation. That is when we can sort of calculate that 7% risk, which is basically the chance that someone would test positive despite not having a family history. That number might change as we learn more about things like what the risks are for certain mutations, but for now that's the number that we quote to patients with no known family or personal history. So in terms of the hereditary conditions associated with MTC, the Rett gene is the only gene that we know of that contributes to an increased risk of hereditary MTC. The umbrella term for conditions related to germline Rett mutations is multiple endocrine neoplasia type 2, or MEN2. This is an autosomal dominant hereditary cancer predisposition syndrome. And that means that if an individual has, there's a 50% chance of passing that on to their offspring. This condition is characterized by a high risk for MTC, of course. And one very important thing that I'll talk a little bit more about is that where precisely on that gene mutation is found significantly impacts what type of risk a person might have. We used to think about hereditary medullary thyroid cancer in 3 buckets. One called familial medullary thyroid cancer, which I've crossed out here, and I'll explain that in a moment. One called multiple endocrine neoplasia type 2A, and one called multiple endocrine neoplasia type 2B. Notice that all of these have in common that very high risk of medullary thyroid cancer, but beyond that, the risks differ between the different conditions. So we used to call or describe families as having familial medullary thyroid cancer if they had 4 or more family members with MTC, but no history or no known diagnosis of pheochromocytomas or parathyroid disease, which are the other 2 main manifestations of MEN2A. But today, as a variant of MEN2A. So even if there is no known history of PHOs or hyperparathyroidism, we would still describe someone with a germline variant associated with MEN2A as having that condition. It is not a prerequisite to have been diagnosed with one of the other manifestations to be considered to have MEN2A. And we just don't have enough evidence to say that we don't need to do screenings for the other manifestations. Many times we can say that the chances of developing those other manifestations is quite low, such as less than 10%, but we do not have the evidence to point us toward which families we can forego screening. A really wonderful table from the 2015 American Thyroid Association MTC guidelines that really breaks down the expected or estimated risks based on the particular location of a genetic difference in the RET gene. So you can see on the far left what sort of looks like a number and alphabet soup a bit, but what this is really representing is the specific genetic difference and where it's located in the RET gene. So if we're thinking about the RET gene as a book, we can think, or excuse me, if we're thinking about the RET gene as one really long sentence, you can picture this code on the left telling us precisely where the typo is in that sentence. Column there where it says risk level. This divides our risk levels into moderate, high, and highest risk. At the very bottom, you can see the 918 germline mutation being associated with the highest risk category. That's the particular mutation that causes MEN2B, and I'll talk about that more in just a moment. In the 4th column there, you can see the estimated risk of developing a pheochromocytoma. In the 5th column, estimated risk of developing hyperparathyroidism. And then in the 2nd to last column, the risk of developing a manifestation called cutaneous lichen amyloidosis, which is a skin rash. And in the column, the chances of developing Hirschsprung disease, which is specifically associated with a few different mutations. So as you can see here, there are some mutations that have 3+ signs in some of the columns. That would mean that there's about a 50% chance of developing that manifestation with that particular mutation. 2+ signs means that there's a 20 to 30% chance. 1+ sign means about a 10% chance. And the minus sign means that it hasn't been reported, or at least hadn't been reported at the time of this publication in that particular mutation. A really useful tool in counseling patients with a new genetic diagnosis, because I can walk through this table with them and say, it doesn't matter what you read online. It doesn't matter if you've read about the highest risk mutation. If your mutation is one of these moderate risk mutations where these other manifestations haven't been reported, we can be a little bit more reassuring than perhaps with a different mutation. And even with the higher risk mutations, we have specific screenings that we can recommend to try to catch or detect these manifestations. Speaking of those, so hyperparathyroidism is one of the other features of multiple endocrine neoplasia type 2A. The parathyroid glands are 4 glands located right behind the thyroid, as you all probably know, and they regulate levels of calcium in the blood. If those glands or a single one of those glands grows more than it's supposed to or more than it should, it causes there to be too much parathyroid hormone produced by the body, which in turn raises the levels of calcium in the blood and causes this diagnosis called primary hyperparathyroidism. Symptoms of this, so even though it is a benign growth, it's not a cancerous growth, it can cause some symptoms that can really interfere with daily life. Kidney stones, fatigue, depression, osteoporosis, stomach pain, brain fog. Obviously not things that we want people to be dealing with for the long term. So we screen for this condition so that an intervention can take place if needed. Diagnosed through blood and or urine tests, depending on what your doctor orders, to look at the levels of parathyroid hormone and calcium levels in the body. The other primary manifestation of multiple endocrine neoplasia type 2A is called a pheochromocytoma, which again is a benign tumor. But in this case, it is something that grows in the adrenal glands and can cause symptoms through the production of stress hormones. Our adrenal glands, as you can see sort of lit up in yellow in this picture, sit right on top of the kidneys. And as the name adrenal gland suggests, it's responsible in part for secreting adrenaline and other stress hormones that, if they are secreted in excess, can cause symptoms such as headaches, anxiety, rapid heart rate, high blood pressure. Again, not something that we want someone to have to endure for a long period of time. So screenings through blood tests as well as imaging can be done for folks who are at risk of developing a pheochromocytoma. 2B specifically still causes the increased risk, of course, of medullary thyroid cancer, but this can be very early onset medullary thyroid cancer, even happening in the first year of life. So causes the increased risk of pheochromocytomas, but does not cause the hyperthyroidism. Folks with MEN2B can also have some characteristic physical features. They may have sort of a long and lanky physical disposition, may have benign growths on the tongue or the eyelids and lips that might be noticeable. And they may also have a condition of the intestine called intestinal ganglioneuromatosis, which can cause GI symptoms for patients with MEN2B. This is a condition where around 50% of the time an individual can represent a new genetic difference or a new mutation in the family, meaning that it was not passed down through their mother or their father. Even in cases where it is a new mutation in a family, that individual who has it can still pass it on to their children. And there would be a 50% chance of passing it on to their children. Surveillance for patients with MEN2 typically includes, of course, monitoring for MTC. We do this through levels of calcitonin, CEA, as well as ultrasound as needed. These patients are also screened for pheochromocytoma, as well as the primary hyperparathyroidism. For patients with the mutations in the 634 mutation, 634 codon, they may see a dermatologist or be monitored for any signs of the rash that can occur on the skin. And for patients who have Hirschsprung disease, GI care would also be needed. Surveillance may be indicated for folks with MEN2B, for instance, if they have any skeletal discomfort or GI problems, they would be followed by specialists for those. Oh, I also did want to mention that these risk levels, I forgot to mention this on this slide back here. These risk levels help us to know where it says moderate, high, or highest risk, help us know how best to monitor patients who have not developed medullary thyroid cancer and how to time recommendations for removal of the thyroid, which is called prophylactic or risk-reducing thyroidectomy. This allows us to know when that might be able to be delayed some. So rather than rushing to remove the thyroid early in childhood for patients who have a moderate risk mutation, for example, they may be able to be monitored through their calcitonin and CEA levels so that as those are staying steady over the years, thyroidectomy may be able to be delayed until a more optimal time with regards to growth and family preference and things like that. Of course, with the highest and high-risk mutations, it is important to really get ahead of that medullary thyroid cancer. And so thyroidectomy is typically recommended much earlier in life. So I want to spend a little bit of time talking about family communication, about cascade testing, which is what we call testing for family members. This is certainly something that is indicated anytime a person is diagnosed with MEN2. All first-degree relatives would have up to a 50% chance of testing positive. So that would include offspring, siblings, and parents. Although we have talked about the possibility of a person representing a new mutation in their family. That's why we say up to a 50% risk for those first-degree relatives. Family dynamics and communication can really be put into the spotlight when a hereditary cancer predisposition syndrome is identified. It could be that there's estrangement in the family for whatever reason, and people wonder, well, I haven't talked to my sister in 2 years. How am I supposed to now just reach out and tell her about this thing that I've discovered about our family? People may not know how to get in contact with their relatives. Now in the days of social media, I sometimes hear people say, well, I haven't talked to her, but I know my cousin follows her on Facebook, so I'm going to ask the cousin to kind of pass along this message. So sometimes in clinic, we sort of get creative as we're brainstorming ways to communicate this information with family. And I think that I have this as my last bullet point, but something that I do really like to emphasize and I'll bring up now is that I think it's important not to try to take on all of this by yourself. I think that either engaging other family members, if you're struggling with thinking about how to communicate this with relatives, trying to seek out a genetic counselor or even a therapist to talk through these things. Heck, I think it's great for anybody to see a therapist, but especially if there's something specific that's coming up that's really causing anxiety or even grief in a family sometimes, to think about these different family relationships and how to communicate this. Another thing that we have to think about too is when and how to start this conversation with our children. For many people, it can be difficult to think about having potentially passed on something to our children. Now, of course, I always remind patients we pass on a lot of things to our children that we don't have any control over. That could be, our stubbornness. That could be our wonderful sense of humor or our love for music. And so we, of course, know that we can't control what we do or do not pass on to our children, but it's still talking about things like guilt or anxiety about potentially having passed on something like this, and thinking about how to start that conversation with children. One thing I like to tell patients or to sort of brainstorm with patients is, one, how have you communicated other difficult things to your family members? Has there perhaps been a grandparent who has passed away or a pet who has passed away? How did that conversation go? And maybe we can sort of build off of how that looked for the family. But more so, I like to think about little ways to incorporate this information into daily life. For instance, if you have little kids, talking about how, you went to see your doctor for your checkup and I'm going to go see my doctor for my checkup. Even starting the conversation that way and sort of easing it in and not just thinking that you have to have one big sit down, here's all of the information that, that I'll ever want to tell you about this genetic condition. We can start having conversations with elementary schoolers and middle schoolers about the different things that families share. We may share our eye color, we may share our faith, and we also may share health problems, and that's something that we can learn about from each other. So I think sort of, one thing I think about is trying to encourage someone to take the pressure off of themselves, that this does not need to be a one-time information dump of, telling everything all at once, but thinking about what's age appropriate and developmentally appropriate for your kids in talking about these topics. Now, of course, if somebody has older kids, even adult children, that conversation can look very different and really may be okay, sit down, I have something important I need to talk with you about, and that's okay too if that's how that looks. We can think about how to present the information in a way that is easy to understand for them. Sometimes a family letter can even help, which a genetic counselor can provide for you to kind of go through that information on paper so that you don't come up with all the words to talk through it at that moment, which I know can be a big challenge. A family letter can also be useful for that other bullet point of estrangement. I have had families where they will send a letter to the family that maybe they haven't been in close contact with recently, but they still want those family members to have that information. To talk about with patients is, what if you tell your family members and they don't want to get testing for something that you think is really important? We hear about this all the time. People who say, I don't want this testing for one reason or another. If you're concerned about discrimination, it could be that fear not knowing and they feel like it's just going to cause them a lot of anxiety to do this testing. Or they may feel like they're going through a lot in their life at this moment, and this is not something that is their priority. That can be a really challenging dynamic to address in a family, because it can be very frustrating for the patient to say, hey, wait a minute, I did what I was supposed to do. I told them about this, and now what? How do I make them get the testing? And so I think that one thing that we need to remind ourselves of is that we certainly cannot control other people as much as we very much want to be able to do that. And we can always encourage family members that and something really that some people don't know is that you can have an appointment with a genetic counselor and still opt not to get testing. We can talk through some of the benefits, limitations, risks of testing. If they come to the decision to have testing after that, great. If not, they at least have the connection so that if they change their mind in the future, that's something that they can go forward with if they want to. So as much as we want to encourage our family members to consider this testing, that's all we can do is encourage them to consider it. And then they have to take it from there. What questions or thoughts or anything does anybody have about this topic?
My 19-year-old daughter has an RET 883 to be. When she wants children, is IVF suggested?
Oh, that's a really, really wonderful question. I'm glad that that was brought up. So for those of you who may not be familiar with what she's sort of referencing, there is a technology that is called pre-implantation genetic diagnosis. This is a technology that's used in conjunction with in vitro fertilization, where an embryo is created and then, or multiple, depending on how the process goes, but the embryos then undergo genetic testing, and then embryos that do not have the genetic difference are implanted, and that is a way to conceive a child that does not have the genetic difference passed on. Now, this is not something that a genetic counselor would ever say is needed or is specifically indicated, but it is something that certainly is an option. And the main reason why I say we wouldn't say that it's indicated is just because it's a very personal decision. And so this is something that we would talk through with the patient to help them come to the decision that feels right for themselves and their families, what aligns with their values and their wishes around this topic. So I would say that that's an excellent topic to discuss with the patient's physician, and they can also get a referral either to genetic counseling or to a reproductive endocrinologist to discuss those options and what those might look like for the family.
In other words, somebody here had a question. Hang on a second.
Yeah, I know that this is a sort of a simple question from my point of view, but I think might be helpful for people in the audience. Is MD Anderson currently doing panel germline testing? And could you perhaps discuss panel germline testing for the people here that might not know what it is?
Absolutely. So this sort of goes back to those slides that I had where you know, if I'm taking a family history and I notice a family history of other cancers, that in particular is when I would lean toward offering panel testing. So panel testing is where we don't just look at one single gene related to hereditary cancer risk, which in this case, of course, is the RET gene, but we instead expand that testing to look at other genes related to hereditary cancer predisposition. Some of you may have heard of the BRCA genes, for example, or Lynch syndrome. These are other hereditary conditions that can cause an increased risk of certain types of cancers. And so oftentimes I do end up doing panel testing for patients, either because they have a suspicious family history, or sometimes people even request it. They say, you know, I've heard about this, or I want to know as much information as possible. And so certainly panel testing is an option that is out there. Anytime we do a panel testing, the chances of finding one of those variants of uncertain significance increases. So that is something I talk to patients about, especially if they're feeling very anxious about their, you know, maybe they've just been diagnosed, and I want them to make sure there is that possibility of some uncertainty when we do panel testing. But it is becoming more and more common. As the cost of testing goes down, more genetic testing labs are offering it. So it is something that's much more accessible, and something I don't hesitate to offer if the topic comes up.
Because in many instances, panel testing is this cost the same as single gene testing.
Yes, that's exactly right. So, and different genetic counselors may view this differently. Some people will really say, you know, this patient only meets criteria for the RET gene. That's the only test I would offer. And then some places probably offer panel testing to every patient, regardless of family history. And I fall somewhere sort of in the middle there. I'd really like to make sure that patients understand the potential benefits and potential risks and limitations of doing broader testing. I think we're likely, as a world or as a field, moving toward more panel testing as we find sort of incidental or unexpected findings. Also brings up the great point of incidental or unexpected RET findings, which are becoming more common. This is sort of the flip side of things. So as people are undergoing panel testing because they've been diagnosed with breast cancer or colon cancer, and it's incidentally or unexpectedly picking up a mutation that indicates that this person has MEN2A. It's a really interesting part of our field that we've had to adapt to.
First question is this. We're constantly finding new mutations, right?
Mhm.
And condoms finding, correct?
Did you say encodons?
In codons.
Yes.
Yeah. So those are constantly being found. For someone who had genetic testing done, blood draw, years ago,
Mm.
and it confirmed sporadic, or I shouldn't say confirmed it, it didn't find a hereditary link.
Mhm.
But as time passes and as more and more mutations are being discovered that might in fact be hereditary,
Mhm.
should a person ever consider retesting on germline at some point in the future?
Great question. I love this question. So for patients who had what's called select exon testing of the RET gene, then yes, we would recommend updated testing. Today's testing reads through the entire RET gene, just like a spell checker. But it used to be about 15 years ago, do you think? Maybe 20 or more years ago, people were having well, more recently than that too, because I have seen some labs still, you know, within the last 10 or 15 years, only looking at specific parts of the RET gene, because those were the parts where most of the mutations were found. And that was done for various reasons, including cost effectiveness and just technology reasons back then. Our technology and the cost has changed such that now we look at the entire gene. And so in order to tell if you need updated testing, if it said full gene, you're good to go. If it said select exon testing, that's when we would recommend updated testing.
Only if they're negative.
Oh, excuse me. Yes, thank you for clarifying that. Yes, and that was the question of if the testing was negative. Yes, if you were positive, no need to do additional testing. But yes, if yours was called sporadic and you're concerned about whether or not you need updated testing, then certainly something you can ask your doctor about too.
And you just look for on your report full gene. If it's full gene, then most likely you're good to go.
That was perhaps a bit simplified because perhaps not every report will say that exactly, but that's in general terms what I look for when I look at a report. But I would recommend asking your doctor about the testing that was done to see if any additional testing is needed. Do you think that was fair?
What happens is that, so the issue is if you've been germline tested and they find a mutation,
Exactly.
if they don't find a mutation in your germline and you've gone on and you've had somatic testing in your actual tumor, and if they find a mutation in that tumor, then you probably do not have MN2.
Yeah.
The mutation that's driving the cancer. But if there's no mutation in either sample, then you should probably think about whether or not they've done genetic testing that they've done.
What about germline and no?
You two sit side by.
There you go.
What about germline testing that finds no hereditary and then no tissue tumor testing due to great surgical results? So I have no idea what my mutation is in my tissue.
Either live in ignorant bliss,
Which is what I've done for 8 years.
or if you've had germline testing,
Well, germline,
and so what year did you have germline testing?
2016.
So you have probably had at least the major exons covered with sequencing. You
Yeah.
probably have not had a full gene, and the likelihood of you having a mutation in one of the super rare things is minimal.
Yeah, and I would even say in 2016, it probably covered everything, just depending on what lab. But yeah, I think that I completely agree with what he said. Yeah.
It's more of a curiosity question. I don't live in fear of it. I don't, it doesn't bother me at all, but I'm gonna ask one more question, then Jeanette or you guys have questions?
Yes.
The risk chart you showed
Yes.
from the 2015 guidelines.
Mhm.
We all know we're waiting with bated breath for the revised guidelines to come.
Yes.
We were told by Dr. Safario last conference, end of this quarter or beginning of 25 quarter. I'm hoping to hear more from him tomorrow as to that. But when you're counseling people now with a chart that's 9 years old, you know that there's new data, you know the revised guidelines are coming out.
Sure.
Can we anticipate changes in that particular chart, and how does it affect how you counsel?
I actually don't know the answer to that. I'm not privy to what might be coming up.
Don't you have access to the MD Anderson prognostic database that probably is going on in the back of your head when you're coming?
So there are certain papers even that have come out since this was published that indicate, for example, that the 804 codon mutations may have a slightly lower risk profile. There are certain mutations that have sort of come out over time where people have studied families with these mutations and say, wait a minute, we see a lot less medullary thyroid cancer than perhaps we might have expected to see. And so already we're incorporating that into our counseling where we say, okay, here's what this says, and here's what research in the meantime has told us. So we certainly are incorporating more recent research into our counseling in many cases.
Okay.
Yeah.
Do you think it's reasonable for retested for rat? I guess I'm just saying personally, for my son, he tested positive, and before I took his thyroid, I asked for. I wonder how many parents do that, or
I see what
I was over the top, or I guess it's how reliable it is.
Percent testing error.
Oh, in what context?
Well, I mean, the wrong blood tube.
Oh, sure, sure.
So in general, lab testing, all types of lab testing, they're It's typically as high as a 5% error rate. So for really, it is actually good to do it twice because then you reduce that 5% error rate dramatically. Problem is getting insurance to pay for it.
Sure.
In my case. Paid for it. So I paid for it myself. I felt that strongly.
Sure.
14-year-old, I just didn't want to. She was like, without thyroid, I had mine for sure. And
Understandable.
I guess it works the other direction. You know, I had a daughter that tested negative.
Mhm.
That's, yeah, really tested. It's a possibility.
If we're testing in, you know, this is a tricky question to answer because I do understand that desire to confirm, especially prior to something like a surgery. But typically, we don't recommend or you know, we don't say that there's an indication for retesting. Now, there have been cases where I have tested, and typically we do that through a self-pay price, which some labs offer as, you know, $250 or so. So there are cases where we have tested due to a wanting to confirm or things like that. But in general, we trust the results of these genetic testing labs. They have put safeguards in place to prevent against things like sample swapping. They have safeguards from so much as, you know, double checking the name and date of birth. I've had the lab reach out to me directly because they say, oh, this person only put their last initial on the case. On the sample, we need to redo the saliva sample because we don't, you know, we can't go based on a, you know, Catherine S as the sample name, even if the date of birth matches and the address matches and everything. So I would say that over time, the labs have kind of adapted to make sure that we can trust their results. And of course, there's always the possibility of human error and things like that, but we would not expect it to be a substantial risk to people undergoing genetic testing. Otherwise, we would recommend routinely that these tests be repeated.
Just, I don't want to sound like everything is 5%. If with automation and taking people out of the picture, it's problematic. The other problem is that within the two families, sometimes 20 people come in and there's Bob Jr., Bob the third, Bob the fourth,
Yes.
and Robbie. And so there's actually a greater chance for error when you have these family gatherings to do family blood testings than sending a single person and time.
If we have, for example, if we have siblings of the same sex that are being tested the same day, I will often do saliva for one and blood for the other, or I will have one have their blood drawn one day, wait a little bit, and then, you know, have them come back in a week and do the other sibling, things like that, just to reduce the chances of any type of accidental sample swap or the sticker going on the wrong tube. When I send saliva sample kits to a home, it has the name of the patient on the box, of course, but I don't send more than one saliva sample at the same time. I wait until one sample has been received at the lab and then send the family a second. So there are certainly safeguards that I like to put in place, even though I fully trust the genetic testing lab and their ability to, like you said, with automation, make sure that the right result is going to the right person. And the reason I mentioned that I do that when they're same-sex siblings is that part of the quality control that they do is even making sure that the sex chromosomes match the reported gender on the test requisition form. So these days, we do not routinely recommend retesting. The lab has safeguards in place to ensure that the right results are going to the right person. And I'm sure the alternative would be a huge liability to the lab, right? That we wouldn't be trusting their results if they routinely had these types of errors. And in today's society, I feel confident we would hear about them as well. And so I think ultimately my message is with testing how it's done now, the methodology is largely similar, if not the same, between different genetic testing labs, particularly with regards to the Rett gene. And we have a solid amount of trust in those methodologies these days.
still doesn't explain to me in our own family of widespread metastatic cancer indolent in the same gene. So this table helps explain, doesn't explain within a family, and I'm always curious why my cousin.
It's a really important question, and I think part of that can go back to, were you in Dr. Who's lecture before this? She was talking about those different acquired mutations that it can occur over time. So I think part of it might be explained by that, but also that's sort of a non-explanation because we can't say why one person's cancer develops it develops certain other mutations while another's doesn't. Part of that can also be the stage at which a cancer is identified and whether anybody has had a risk reducing surgery. So all of those different factors can play in. And we oftentimes though don't have a good explanation.
Question about the 7% rule.
Oh, sure.
Going back to that, I'm going to say how I understand this to clarify that I'm correct in my understanding, because that's kind of a precursor, that understanding, precursor to my question.
Okay.
My understanding is the definition of that would be that 7% of those who are apparently sporadic will end up with a hereditary finding, and that apparently sporadic has been determined through the questions, the family history.
Correct.
It's got nothing to do with testing. Apparently sporadic is just how do people answer the questions, what's his family history? And that person's maybe physical history, whether they've had other physical issues.
That's right. That's
Okay.
right. So, and I want to make one point of clarification because I think that you brought up a great point earlier about the somatic testing that can really reduce our suspicions of a hereditary factor. Some other type of somatic mutation is found on tumor testing. I wouldn't necessarily quote that 7%, but that's sort of a newer addition to our risk assessment.
Okay, but what that does not mean that a person who has genetic testing and it comes back with no hereditary findings, which now makes them sporadic, that does not mean that there's 7% of those who in fact are hereditary, but it's like a
And just don't know
Yeah,
it.
they don't know it.
Yes, you're exactly right. And I'm glad you clarified that point.
Okay.
So the way that we really define it is by the presence or absence of a RET mutation. And for
Sure.
now, and of course we may always learn more in the future, germline. For now, the way that we would classify that is that if the testing has come back and the testing came back normal, negative, no germline RET mutation found, that's when we can officially classify it as sporadic.
Very
Does
much.
that
Yep, it does.
clarify?
It
Okay,
absolutely
perfect.
clarifies, and I will stop now.
So difficult with MEN2B because so many are new mutations in a family or that de novo mutation. And the best that I do is talking about this. I am teaching the next generation of genetic counselors, having residents and fellows and everybody like that shadow with me in clinic so that they can hopefully learn more about these conditions. I don't know of any particular sort of widespread or national charges to try to inform more about this. But I think we all just need to keep doing our part to inform the providers that might notice some of those features, pediatricians, things like that, that might notice some of the early features that could be suspicious for MEN2B. Definitely have a long way to go for that.
You said sporadic is usually, the tumor is usually unilateral. But you do see it bilateral sometimes?
Yes, I mean, it's, I sort of like to say that cancers don't read the textbook. So while we can say certain things have trends or we see this more often here, that more often there, that's not always the case. And I don't have the specific numbers, unfortunately, but somebody like Dr. Who might. I'm not sure. What?
Or grub.
Oh, yeah, that's true. Or Dr. Grubbs, that's right. Yeah.
Thank you very much.
Thank you.
Yeah.